Now this is the first time in my life. It's impossible to stand on the podium where Professor Ralph Defonso is supposed to stand. But I think you will hear the story as to why he could not make it. And so I'm a last minute I won't say, I've had 3 hours of notice. So I'm a stand-in now. But this topic is interesting. There's a new molecule, not a new molecule, it's a new combination which is going to be launched in India pretty soon. So you'll be getting this molecule. In the US, they already have it. This is the empagliflozin, linagliptin, fixed dose combination, a leap towards holistic type 2 diabetes management. I think I like it because yesterday I spoke about holistic management of type 2 diabetes, and I told you that holistic management is management of blood pressure, cholesterol, diet, exercise, and subsequently glycemic control. So now I'm going to focus today on glycemic control alone. We'll start with the case, which makes it interesting. 44-year-old male, type 2 diabetes for 4 years, weight 68, BMI 27.5, a little bit obese, on metformin 1 gram twice daily for the last 4 years. HbA1c is 8.6, fasting 155, PP 270, blood pressure is okay, EGFR 104, SGPT is 35. Intentionally is not made as complicated as what Sanjay was showing to us when we were in the panel. It's straightforward. HbA1c is not 99.510 where you have to think about insulin. This gentleman is only on 1 OHA, metformin 1 gram BD for the last 4 years and has got an HbA1c of 8.6. Renal, liver, etc. is okay. So question is, the scenario is type 2 diabetes uncontrolled on metformin. What should be the HbA1c target here? I'll read out the values. Please raise your hand. Let's make it a bit interactive. How many people want HbA1c of 6%? How many want 6.5? How many want 7? I'll go back again. How many want 6.5? How many want 7? How many want 7.5? Nobody. So this is why ADA ESD confuses you. It's like 6.5 to 7. If you ask me, I would go 6.5. 44-year-old, no baggage. Why should I even go up to 7? I'll be happy with 6.5. So what will you do now? Add a single drug or a combination. So I'll take a vote again. Add metformin, 1 gram BD, HbA1c is 8.6. Nothing stops you from adding anything. You can afford. So how many people will add a second drug, metformin plus 1 more OHA? And how many would add 2 more drugs, a combination, i.e. you have metformin plus 2 other drugs? Equally divided. Fantastic. So let's go on. Good glycemic control is the cornerstone of type 2 diabetes management. I don't need to tell you this, August audience. We need to get weight control, physical activity, healthy eating. We use monotherapy, dual therapy, triple therapy combination. Target an HbA1c of 6.5. Of course, as we all know, we need to target the HbA1c based on the underlying characteristics of the patient that you are seeing. But we discussed this yesterday also. Today, Dr. Arvind also discussed. We do not get our HbA1c under control. Look at the left panel. Target HbA1c less than 6.5 to 7. A bit quarter to a third to a half of the patients do not achieve HbA1c control. And glycemic control tends to decline over time with monotherapy. This is data from UKPDS, people who are on metformin alone. If you see people less than 7%, at 3 years were 44%, at about 6 years were 34%, which tells you that monotherapy is going to fail. This is an elaborate way of doing a study, reanalyzing it, and just to say that monotherapy is going to fail over time. You've seen this slide probably 1,000 times before. This is what ADA ESD would want you to do. Give 1 drug, fail for 3 months, give second drug, fail for 3 months, give third drug, etc. But I think we are fast moving away from that. We are moving into combination therapy. Give early combination therapy, get target HbA1c. Whether that's going to have micro and macrovascular benefits in the long term, yes, we need data on that. We will get data on that. But just by the fact that you do not have data on macrovascular complication protection does not mean that you throw away combination therapy. And this is, Ralph was supposed to speak from here, and this is Professor Ralph Defonso's slide, that from triumvirate to aminous octet, if you want to target all the pathophysiological defects, you need to use combination therapy. Drugs used in combination in the correct manner, based on known pathogenic abnormalities, and started early in the natural course of history. So treat with active intervention rather than treat to fail, and the UKPDS data, and you can see many other data, etc., which shows that as if you target HbA1c early, you can get benefit later on. So this is the combination, as we discussed just now. Half of you would add metformin plus something, maybe sulfonylurea. That's the commonest added worldwide. Even in US, second commonest drug is sulfonylurea in 54% of patients. In India, probably we don't have hard data, but probably 70 to 80% is sulfonylurea. But if your patient can afford, I would recommend that probably you may move on to something better with drugs with the more pleiotropic effects. The debate would be GLP-1, but as we discussed in a panel, GLP-1 is not affordable even in the US, leave alone India. I mean, yes, if you have a patient who can afford GLP-1, I think the best second combination to metformin would be GLP-1 for n number of reasons. We can debate that later. But majority of your patients will not be able to afford GLP-1. One is injectable, second is affordability. So you're next left with two other drugs, SGLT2 or DPP-4. Now, we've always been on these various meetings where we have debated whether it should be DPP-4 or SGLT2. What I'm trying to tell you today is why not have both? So this is the octet. You've seen this 100 times. And in this octet, if you want to, see, if you take sulfonylurea, it doesn't deal with any of the 8 pathophysiological defects. You take metformin, it deals with only 1, possibly 1.5. Metformin works on hepatic glucose output, and maybe to some degree, on the top right, if you see glucose uptake, insulin resistance. But now, I'm going to combine these two drugs for you. Patients already on metformin. I am suggesting, why not use SGLT2 and DPP-4? Why? Look at the various pathophysiological defects that you're going to target. With metformin and SGLT2 on the top right, you're dealing with the insulin resistance. With SGLT2, you're dealing with the kidney aspect. Insulin secretion, of course, DPP-4 inhibitors. If you're dealing with metformin and DPP-4, you're dealing with the hepatic glucose output. And DPP-4, of course, causes glucose-dependent insulin release and glucagon suppression. So you're going to target 6 of the pathophysiological defects. My request to you is move away from stepwise treatment. Try to use combination early so that you can target multiple pathophysiological defects. Why combine SGLT2 and DPP-4? You must have heard this n number of times again. This slide summarizes that. One is insulin dependent, one is insulin independent. You can just read along. One decreases glucagon and one increases glucagon. Weight neutrality, whether on the other side you have weight reduction. So all this fight we had all the time, whether SGLT2 or DPP-4. If affordability is not an issue, combining them is the best bet, because if you combine, you get the best of both worlds. You get the raised glucagon SGLT2, but the DPP-4 tries to suppress that. You get the weight reduction advantage of SGLT2. You get the insulin independent action of SGLT2, whereas you get the various other pleiotropic effects of DPP-4. So indication, empagliflozin and linagliptin fixed dose combination, basically you can use it anywhere, indicated as an adjunct to diet and exercise to improve glycemic control. There are 2 strengths which are available, 10 plus 5 and 25 plus 5. We don't know the cost. I don't know the cost. Supposed to be launched next month. So when the cost comes, then we can all decide which one you want, 5 plus 10 or 25 plus 5. Now these are the various, I'm supposed to take you through them because these are the various trials which have been done. Empagliflozin, linagliptin, fixed dose combination. The initial combination studies support the US submission, which was, if you are interested, 1275.1, but I think that's too much. I will take you through 4 studies of combination of SGLT2 DPP-4, that is EMPA and Lina, together, and then one after the other added. If you see, it was approved in US in Jan 30, 2015, and the approval in EU was in 2016. And now it's approved by DCGI September 2017. And generally, there's a lag period between the approval from DCGI plus the launch. So the launch, I'm told, is going to happen very soon. You will be seeing this combination in your armamentarium pretty soon. Now, whenever you want to combine a drug, you want to make sure that one drug is not affecting the working of the other drug. So you do something called PK/PD studies. What you're seeing here is the PK study. When EMPA and linagliptin were given together, what happened to the plasma level of each individual drug. So on the left-hand side, if you see empagliflozin, when given alone, 50 milligrams once daily for 5 days, and then subsequently EMPA 50 milligrams once daily and Lina 5 milligrams once daily for 7 days. Empagliflozin levels were measured. There was a slight decrease in the empagliflozin level, which was statistically significant, but not clinically meaningfully significant when you did the PK studies for the EMPA add-on, EMPA-Lina. If you come onto the Lina side, on the right-hand side, if you see the Lina plasma concentration, which was measured, Lina was given 5 milligrams once daily for 5 days, and then Lina plus empagliflozin was given. If you see, the curves exactly match over each other. So it's a long-winded way of telling you that if you combine empagliflozin and linagliptin, you're not changing the properties of any of the molecules. You're getting the same drug combination. So it's a nice combination to have. One is not affecting the action of the other. These are the 4 pivotal trials. Now, I'm supposed to take you through them. There might be a lot of data, might be a bit boring, but bear with me. What were these studies? On the left-hand side, if you see, it's initial combination, initial EMPA-LINA FDC in drug-naive patients, like these are type 2 diabetic patients, not given metformin, but they were given first-line combination of an SGLT2 plus DPP4. In your and my clinical scenario, probably this will happen in 5 to 10% of our patients who are metformin intolerant. If they're metformin intolerant, then this study applies to you. But they have to do this study for regulatory requirements to show that in drug-naive patients, when you give the combination, you get the desired results, don't do any harm. Our case scenario, 4 years on metformin 1 gram BD, HbA1c 8.6% is the second trial. The second trial was EMPA-LINA FDC on metformin background. Now, sequential therapy, empagliflozin patients is already getting, it is on metformin background, everybody gets metformin. They were getting an SGLT2 inhibitor, and then a DPP4 inhibitor, linagliptin, was added. Whereas the 4th study, patient was getting metformin plus DPP4, and an SGLT2 was added. You have been to various meetings where you have kept discussing which should be second, DPP4 or SGLT2. I think if you marry them both, that fight completely disappears. And let's see, if you marry them both, will make the patient spend 20, 30 rupees extra per day. Is it worth it? Do you get the results that you desire? So let's focus very quickly on the EMPA-LINA FDC in drug-naive patients. I will take you through this trial design only once, because this trial design is almost the same for all the trials. There was a screening period, there was a 2-week placebo run-in period, and there was randomized 1:1:2. So basically 1:1:1:1. What were the things we'll see? It was done in 22 countries. I don't know why it mentions including USA, because we're in India, but yes, USA was included. And it was a 24-week analysis, and there was a 52-week analysis. What were the various arms? The first one was EMPA 25 plus Lina 5. It's a FDC, fixed dose combination, 1 pill having both. Second one was EMPA 10 plus Lina 5. Third one was EMPA 25. Fourth arm was EMPA 10. And the last arm was Lina 5, because we know that most of the time we use linagliptin, 5 milligrams a day in most of our patients. That's a big advantage of Lina. 5 milligrams, give it, forget it, whatever is the renal function. So this was the trial design. The same trial design keeps following on. Now what happens? What does common sense say? You combine both, you will get better HbA1c reduction. And that's what the next slide tells you. If you look from right to left for you, probably. Let's start with Lina 5 milligram, 0.67%, EMPA 10 milligram, 0.83. Now just focus below. HbA1c to start with is 7.9 to 8%. So don't go home thinking that Lina and EMPA are weak anti-diabetic agents, because the starting HbA1c is 8. If you start with an HbA1c of 10 or 11, you will see 1.5 to 2% reduction with a combination. But here you're starting with an HbA1c of 8.5 to 9. That's why you're seeing a 0.6% with Lina, 0.83% with EMPA. EMPA 25, slightly incrementally better, 0.95. And now you come to the combination of EMPA 10, 5, you get 1.24. Interestingly, these are trials, EMPA 25, 5, you get an HbA1c reduction of 1.08. Those of you who cannot read all the p-values, take it from me, both the combinations, FDC 25, 5 and 10, 5, does better than any of them individually. EMPA 25, EMPA 10, Lina 5. Now, I was discussing with them a comparison of EMPA 25, 5 and EMPA 10, 5. It would be nice to have, but we don't have that statistical analysis. Change in HbA1c over 52 weeks, as I said, 24 and 52 weeks. I mean, it's a no-brainer, but you have to show this. You have to show that it works in patients before you can get approval. If you see the lowest 2 lines, those are the combinations of EMPA 25, 5 and EMPA 10 and 5. And of course, they bring the HbA1c down not so rapidly, but by about 6 weeks. And if you see, it's maintained for 1 year. This is in metformin naive patients. Now come to the common clinical scenario which you and I will face. Patient is on metformin, you're going to add a second drug. Why did half of you raise your hand for 2 drugs combination? Because HbA1c is 8.6. I want 6.5 in a 44. If I give individual drug, 6 months or 9 months or 12 months down the line, I will add the third drug. Why have this glycemic load for next 6, 12, 9 months? So that's why half of you who said combine an SGLT2 and a DPP4, probably you were thinking on that wavelength that you want to get the 8.5 down to 6.5. That's why you're combining. So this is the trial. You have to prove to the regulatory authorities and of course to yourself that if you do this combination, you're getting the desired result and you're causing no harm. So of course, as I said, somebody on metformin gets a combination of DPP4 and SGLT2 inhibitor, you would expect what? HbA1c should be more than the individual drug. And that's exactly what happens. As I said, the trial design is exactly the same. 2 weeks follow-up, 1:1:1 randomization of 25-5, 10-5, 25 MPA, 10 MPA, 5 LINA. And if you see the HbA1c reduction, now this is if you see the baseline value is even tight, 7.9 to 8.0%. Not like our patient who was 8.6. And if you see LINA, 0.7, MPA 10.6, MPA 25.6, and if you see MPA 10 plus 5, 1.08, and MPA 25 plus 5, it is 1.19%. Again, those of you who cannot read the p-values, take it from me that both the combination, FDC of 25-5, 10-5, was statistically superior when compared to MPA 25, MPA 10, and LINA 5. Again, the same thing when it's followed up for 52 weeks. Again, no-brainer. You can see that the combination 25-5 or 10-5, HbA1c reduction is more and it is stable. What percentage of your patients get an HbA1c to goal? The probability of having an HbA1c less, this is people who had HbA1c more than 7% at baseline, getting an HbA1c to less than, basically how many percentage of patients get an HbA1c less than 7? That's what you and I look for. 61.8 and 57.8% with the combination, as opposed to 32, 28 and 36 with each individual drug. So again, a very simple common sense concept that if you combine a DPP4 and an SGLT2, you will get a better glycemic control, you will get more patients below HbA1c less than 7, and that's what this study shows you. Now let's come to the next set of studies. So what happens here? People here are on metformin. This is what you and I have been doing so far. We don't have the FDC with us. People are on metformin and empagliflozin, and you add a linagliptin. Okay? Are you following? And on the other side, people are on metformin and a DPP4 inhibitor linagliptin, and you're adding an SGLT2 empagliflozin. This is not a fixed dose combination. This is what probably you and I have been doing so far till the FDC comes to us. So you've seen the FDC studies, now see the studies. It's basically almost the same, so I'm not going to bore you with the entire trial data, all the subtleties. I'll just show you one slide of each to show that if you see, this is people on metformin plus linagliptin. On top of that, you're adding an SGLT2. Again, it's a no-brainer that when you add an SGLT2 inhibitor to a metformin DPP4, you will get better HbA1c control, and that's what happens here. If you give MPA 10 or MPA 25, you get slightly more HbA1c reduction, which is statistically significant. And the other part, patient is on metformin DPP4, you're adding an SGLT2. Again, if you see empagliflozin on metformin plus empagliflozin background, if you add linagliptin, you get better HbA1c reduction. So what have we taken you through? I've taken you through a person who's on metformin, 1 gram BD. You have to intensify your therapy. You have to decide whether you want to intensify with one drug or two drugs. If HbA1c is 8.6 in this gentleman, see, this combination need not be given to everybody. You have to decide whom you want to give. So if you want to bring the HbA1c down by 1.5, 2%, adding metformin DPP4, metformin sulfonylurea, waiting for 3 months, 6 months, we are trying to move you away from that concept. Get early combination therapy. So if you want to combine, what you have seen 4 studies, fixed dose combination in insulin-naive patients, metformin, background of SGLT2 DPP4, and sequential addition of the same drugs. In all cases, it works. It gets HbA1c down more than each individual drug, and the people achieving a target of HbA1c less than 7% is naturally, obviously, higher. But as I said, studies need to be done in a randomized control way to get that point across. Now, what are the various pleiotropic benefits? It is a combination of all the studies. I mean, again, weight loss is not happening because of the DPP-4 inhibitor, because there is empagliflozin. If you see the weight loss, Lina alone 0.7 kilograms, EMPA 2.5, EMPA 25 is 3.2, and if you combine, you get almost the same, 2.6 and 3.0 kilogram. There's significant systolic blood pressure reduction. Everybody in this room knows that if you give empagliflozin, you get about 2 to 4 millimeter reduction in systolic blood pressure, and that's exactly what is happening. When you're adding it with linagliptin, you're not losing the systolic blood pressure reduction of empagliflozin. And also same thing with diastolic blood pressure reduction. Those of you who have read the EMPA-REG trial in detail, you would have known that the diastolic blood pressure reduction in the EMPA-REG outcome trial was about 2 millimeter, and that's exactly what happens here. When you combine with linagliptin, you still have the 2 millimeter reduction in diastolic blood pressure as you had seen in the EMPA-REG outcome trial. So the last question which remains is, okay, you have shown us a very nice fixed drug I mean, it's not my molecule of a company. I'm just showing you the data. You have shown us a nice data that when you combine, you do not have any effect on the pharmacokinetic properties. When you combine pharmacodynamically, you have shown us that you get HbA1c reduction, which is more than each individual component. You have shown that you maintain the weight loss, maintain the diastolic and systolic blood pressure reduction. Then the last question would be, when you combine these drugs, what happens to the safety? Is it going to harm my patient? Of course, it's going to harm your patient on one count. And what is that? Everybody shout. It's going to harm on the pocket front. So if the pocket front harm is accepted, then of course let's come to science. As we were discussing the insulin thingy. See, US, what were the answers you got? GLP-1. Any patient GLP-1? By show of hands, I want to see. At that time I couldn't ask because Manoj was shouting at me. How many of you have more than 10 patients on GLP-1 for 6 months? 10 patients on GLP-1 for 6 months. Here, I expect all three of you. So can you see? It's very smart, sexy to say GLP-1. GLP-1 has got pleiotropic effect. Where can you afford GLP-1? So what is the next best GLP-1? DPP-4 inhibitor. If you give GLP-1, you get your GLP-1 levels rising in pharmacological levels. That's why they have nausea, vomiting, weight loss. DPP-4 inhibitors do not give nausea, vomiting, do not give you the weight loss because the GLP rise is about 2 to 4 folds. Linagliptin claims 4 folds, sitagliptin claims 3 folds, Vilda claims 2, but these are all trials done in Petri dishes, so it's very hard to say, but generally, ballpark figure is your GLP-1 level goes up by 2 to 4 folds when you're giving a GLP-1 DPP-4 inhibitor, and when you're giving a GLP-1 agonist, which most of us in this room cannot afford to give to our patients, the GLP-1 level goes into pharmacological level. That's why you got such massive, not massive, reasonable weight loss when you give GLP-1. So coming to the safety profile, when you combine both, do you do any harm? What they have done is, this safety profile, I told you these are the 4 pivotal trials they have had for regulatory, for the authorities. They've combined the safety effect of the initial FDC when given naive or given on the background of metformin. And what happens is a pooled analysis. On the drug naive side, there were 677 patients, and on the metformin background, there were 686 patients. A very busy slide. We have time, so I can take you through, but you will get bored. Basically, any adverse effect, one or more serious adverse effect, death, hypersensitivity reaction, pancreatitis, nasopharyngitis. If you want, you can eyeball it. It's exactly the same. So there is no difference if you're using Lina, EMPA, or if you're using the combination. Pancreatitis, interestingly, there was one in Lina and one in the EMPA-Lina arm, but then one pancreatitis doesn't make that much of an issue. Now, comparable confirmed hypoglycemic adverse events. Now, as I said when I was giving my lecture yesterday, don't go home thinking that metformin doesn't cause hypoglycemia, DPP-4, SGL, they can cause hypoglycemia to the tune of 2 to 4%, and that's exactly what you're seeing in this trial. If you see the hypoglycemia was 1.5%, 2.2, 2.2, 1.1, 1.8. So, idea is when you use them independently or when you use them in a fixed dose combination, FDC, there is no worsening of the effect. Now, urinary tract infection, again, that is a big question. If in the EMPA-REG outcome trial over 2.1 years of follow-up, 3.1 years of follow-up, you realized that there was no increased risk of UTI with empagliflozin versus a placebo arm. There's no placebo here, but they're comparing with LINA, EMPA, and the FDC. Again, if you see, there's no increased risk of UTI, and this is the problem. Those of you in this room who have used SGLT2 know that it's a problem. GTI is a problem. You have to warn your patients about fungal infections, maybe give them whatever cream that you like. But when you combine, this is the interesting part. This is the only interesting part in this whole talk. If you take linagliptin, 2.6, EMPA 10, EMPA 25, 6.5% of patients had. When you combine, the GTI is less. And when you ask the question to Rajiv Kovil, because he told me I need the CGMS workshop. So he has to answer this question as to why there is decreased GTI when you are combining EMPA plus LINA. I've got 2 slides to give the answer. Shall I skip them? Okay. So this is a meta-analysis done by Fadini et al. Where if you see that all the small trials where they use in combination of DPP-4 and SGLT2, if you see the risk of GTI goes down. Now, when all of us who have used SGLT2 inhibitor, empagliflozin, we know that you do get a fair few patients complaining of GTI. GTI is not an indication to stop empagliflozin. If they get recurrent attacks of GTI, despite maintaining good hygiene, that is the time when you have to stop empagliflozin. But if you're combining EMPA with DPP-4 inhibitor, this was not expected. This is what they found when Rosenstock, Refronzo, Levin were doing their trials. They found that, interestingly, there was slightly less, I won't say hugely less, but slightly less GTI. And then all sorts of theories have been given in, which Dr. Rajiv Kovil will answer if any of you have a question. The only theory that I can answer is probably there's inhibition of the DP4 enzyme in some bacteria and fungi, which might be causing reduction in the GTI. So, in summary, EMPA, LINA, FDC, which you're going to see probably in 4 to 6 to 8 weeks' time, depending on which part of the country you are, offers high efficacy and convenience of a single tablet. We have been talking about compliance. So it's easier if a patient has an FDC with 2 drugs. 2 to 4 times higher odds of patients reaching the goal HbA1c compared to each individual alone, no-brainer. Early achievement of glycemic control, you saw in that graph, they were achieving it early and they were maintaining it for the whole year. Combination offers extra glycemic benefits, like the extra glycemic benefits of empagliflozin are not lost. Weight reduction, systolic blood pressure reduction, diastolic blood pressure reduction, all remains maintained. There are no additional safety concerns when you combine both, and possibly lower the genitourinary tract infections might be lower, but you and I, all of us, need to use this combination in a large number of patients in our clinical practice to find whether that is indeed true, because these are randomized controlled trials where everything which happens in an RCT may not transfer into a real-world evidence. With that, I will stop. I've taken you through 4 trials about the fixed drug combination. We are excited because it's nice to have a combination. Always we were talking about combination of SGLT2, DPP4, how one helps the other. Now we have it, and when it's launched, you are welcome to use. As I said, the only one caveat in our country is affordability. But having said that, there are a large number of type 2 diabetic patients. I'm in Pune, such a rich city. So there are patients who can afford it. If patients who can afford it, please give it to them. When I say GLP-1, when I laugh, there are people in this country who can afford GLP-1. So if somebody can afford, offer it to them. Don't push it on to them. That's what I do. I offer GLP-1 to 10 patients, only 1 accepts it. I'm happy with that. If they refuse, I said, fine, it's okay. If somebody you look at and you know cannot even afford it, please don't offer it. Don't unnecessarily put them under pressure thinking that there's a nice drug I cannot afford, maybe I'll die. So there are patients who can take this combination. If they are, you're welcome to use it. Any questions? Chairperson, sir.
The session is open for discussion. We can have a couple of questions at the most because we're running short of time. Yes, please.
Do you foresee any cardiovascular protection? When you are using individually EMPA, cardiovascular protection you can...
Sir, we can...
what about the combination?
So, as you saw, there was no change in the PK-PD. PD improves, there's no change in PK. If there's no change in PK, probably you should get the same cardiovascular benefits like you got in the EMPA-REG outcome trial. I don't think there's any need for another CVOT with this fixed dose combination. Chairpersons, do you, any comment on that?
Because some studies have, some people are suspecting that arrhythmia portion that is going to give some protection from EMPA may be lost when you combine with this because of glucagon. When there is, when you're using
Okay. So you are saying the sudden death which was reduced in the EMPA-REG outcome trial might be mitigated because glucagon. See, I don't know whether you were there on the talk by Dr. Vivian Fonseca. Out of the so many mechanisms of EMPA causing cardiac protection, glucagon was there till 6 months ago. That wasn't even there in his list yesterday. I mean, it's a good speculation. It's a nice thought. Answer is I don't know whether that will happen or not.
JJ, excellent talk. Just a quick question. There was this meta-analysis which came out, and I'm not very sure of the journal. It's a Chinese paper which was published, and they quoted saying that usually the urinary tract infections are more common with dapagliflozin, whereas the mycotic infections are more common with the other gliflozins. Do you find this segregation in our set of population? This was a meta-analysis, almost about 59 studies that they quoted.
I mean, Sanjay, I mean, I don't think there's any such difference between the molecules with regards to UTI versus GTI. I mean, if you ask for my own personal experience, I've not used it in 10,000 patients to give you I've used in a fair number of patients. I would think it's the same with 3 molecules. I don't know whether they have any difference of opinion.
I don't think clinically, Sanjay, we've seen that whether any of the difference between any of the 3 SGLT2 inhibitors. But I think urinary tract infection has been overemphasized, but in clinical practice, we actually don't see that much of it. Genital infections, we do see with all the 3 SGLT2 inhibitors.
No, he wants to know the differentiation. He says in one has more UTI, other has more GTI.
There has been, then what causes one to cause more of UTI and the other one to cause more of...
I don't agree there's a difference.
Even I don't agree with that.
And just one quick comment. You know, the combination having less of GTI could well be because of better glycemic control.
I can't hear you.
The combination having less GTI could be because of better glycemic control and better cell-mediated immunity, rather than having to do with the drugs per se, but better control of glucose.
This is more of my opinion regarding this combo, which is likely to be launched. You had already presented a small 4 papers or studies. Is extrapolating this and putting it in 2 programs. One is diabetic remission program, and boldly going ahead, if we get good results, into diabetic curative programs. 12 years back, in our hospital, we had started diabetic curative programs. Initially, it was the days of stem cell, which did not materialize. We went into bariatric procedures, and today I think so, probably this combo is giving near results, very near results of post-bariatric surgeries. Is we are achieving a comorbidity treatment management with SGLT2, at the same time improving the beta cell mass with the gliptins and DPP4s. And therefore, probably this combo have a hopes in diabetic remission programs. Is there some studies that sustain effect of 6 months of combo in persisting the C-peptide levels and sustaining the weight loss?
Sir, I mean, this combination is nowhere near bariatric surgery. Bariatric surgery is much more effective than a combination of DPP4 and SGLT2. I mean, we can discuss later on. Even for that matter, metformin, GLP-1, SGLT2 also will not do as good as a bariatric surgery does.
Agreed. Okay.
We'll discuss.
On that note, we must bring this... Sorry, please. Can we move on to the next session, please? Thank you.
Thank you.